how to do clinical examination in endocrine diseases. If a patient comes with endocrine disorder, okay, how to proceed further, how to take history, and how to physically examine and how to order investigation. This is a very basic topic, So after this, I'll move on to the thyroid disorder. Now see here, please pay attention. Patients with endocrine disease present in many different ways because they either can present with the deficiency state or excessive state of the hormone. Let's take example, hyperthyroidism and hypothyroidism. Hyper means excessive thyroid hormone level. Hypo, decreased level of thyroid hormone. Hyperpituitarism and hypopituitarism. Hyperadrenalism and hypoadrenalism. So different terms are there, So either they present with decreased hormone or excessive hormone. Now, the presenting symptoms are often non-specific and long-standing. So sometimes a lot of the differential diagnosis should be thought because the presentation is quite vague or non-specific. And if we do not identify them in time, they may be quite long-standing also. In many patients, endocrine disease is asymptomatic and detected only by routine biochemical test. Absolutely. Many of the patients in early stages of thyroid disorder are asymptomatic. I'm talking mainly about hypothyroidism. Okay, so how to diagnose that hypothyroidism if there are no sign and symptom? It is by lab test. Just order thyroid function test, and if that thyroid function test is abnormal, you think about hypothyroidism. So that's the way. Diabetes and thyroid disease are the most common endocrine diseases in clinical practice. So the person who specializes in endocrine diseases are known as endocrinologist. And in that endocrinologist clinic, okay, the two important disorder which comes are diabetes and thyroid disorders. So that's why in our endocrine discussion also, we'll mainly focus on these two important diseases. But don't worry, we'll cover other as well. Now, what are the common presenting symptoms of endocrine disease in clinical practice? Lethargy and depression. Lethargy and depression is one of them. It is seen in hypothyroidism, diabetes, hypogonadism, adrenal insufficiency, and Cushing syndrome. Okay, there are multiple reasons for lethargy and depression. Some are direct, some are indirect, but these are commonly seen in these types or these causes. So hypothyroidism, one of the very important manifestations is lethargy. The patient, okay, is quite lazy. The patient develops sleepiness all the time. Diabetes, as a result of, for example, diabetic ketoacidosis. In case of type 1 diabetes, that's a very important complication. Patient develops hypovolemia. Patient is dehydrated. And that type of patient, if there's a severe dehydration, will definitely have lethargy. Okay, so other things are also there. Weight gain. Weight gain is one of the common symptom or presentation in endocrine disease, very commonly seen in hypothyroidism and Cushing syndrome. Now, hypothyroidism is characterized by deposition of connective tissue substance called mucopolysaccharide in different parts of the body. As a result of this, hypothyroid patient gains weight. This is one of the very important reasons. Whereas in Cushing syndrome, the appearance is very funny. Actually, there is redistribution of fat from the extremities towards the central part of the body. Okay, the person develops big tummy. The fat is deposited around the belly, but the limbs look quite thin. So this is a type of weight gain in case of Cushing syndrome. Whereas weight loss can occur in thyrotoxicosis or hyperthyroidism, opposite of hypothyroidism. Adrenal insufficiency, okay, means decreased level of adrenal hormone, and Diabetes, especially the type 1 diabetes patients, are very thin. But even type 2 diabetes patient, when they start to develop type 2 diabetes, they lose weight. They lose weight during that time. But usually they look obese. So these are some of the important manifestations. Let's move on. Now, what are the other common symptoms or presenting symptoms of endocrine disease? See here, amenorrhea and oligomenorrhea in case of females. Amenorrhea and oligomenorrhea. Now, amenorrhea and oligomenorrhea. Can you tell me the meaning of this term first? What is amenorrhea?
So amenorrhea
Loss of
means there is no
menses.
Amenorrhea is
menses.
absence
No
and
menses
oligo
and
there is decrease.
oligomenoria, less
Absence and
menses, less
no
menstrual flow.
menses and oligo.
Exactly, exactly. All the students are answering correctly. Amenorrhea means, absence of menstruation. Okay? There is no menstruation now. Amenorrhea. Oligomenorrhea is decreased bleeding, decreased flow, decreased amount, okay, of blood loss during periods. So oligomenorrhea. Now, menopause is one of the commonest cause of amenorrhea. Now, this is a permanent type of amenorrhea because after menopause, there is no menstrual cycle. Polycystic ovarian syndrome is another disease, also known as Stine-Leventhal syndrome. Stine-Leventhal syndrome. So that is a important question which is asked in the exam. So try to remember the synonym here. Stine-Leventhal syndrome, also known as polycystic ovarian syndrome. And some of the female, they develop this condition where there are multiple cyst formation inside the ovary, and androgen hormone is released in excessive amount. And because of the effect of the androgen hormone, okay, there are multiple signs and symptoms. One is amenorrhea or oligomenorrhea, another is hirsutism, and another, they look very obese or overweight. Hyperprolactinemia is another cause of amenorrhea. Hyperprolactinemia. Okay. Thyrotoxicosis, premature ovarian failure, and Cushing syndrome are some other causes. Now, another type of common presentation is polyuria and polydipsia. Very important, like diabetes, okay, diabetes mellitus and diabetes insipidus. So these are two types of diabetes, which are quite common in clinical practice. Mellitus is much more common than insipidus. So we all know diabetes mellitus is because of, what is the cause of diabetes mellitus?
Because of high glucose in the blood.
Absolutely. But what is the cause?
Decrease
So
insulin in the
decrease insulin in type 1 absolute
insulin sensitivity is decreased.
deficiency and the type 2 relative deficiency.
Exactly. I'm getting the answer from all of the students. Very good. You already have a bit of concept regarding diabetes mellitus. So diabetes mellitus is absolute or relative deficiency of insulin hormone. Absolute means there is no insulin hormone at all. This is called type 1 diabetes. And relative deficiency means type 2 diabetes, where decreased amount of insulin may be there, okay, or the insulin is resistant, okay. Insulin is resistant in the tissue level. There is a problem with the receptor. So that is type 2 diabetes. Whereas diabetes insipidus is about, okay, the ADH level, okay, antidiuretic hormone. If antidiuretic hormone is less, okay, if antidiuretic hormone is less from the central level, that is from the hypothalamus or pituitary level itself, we call that central diabetes insipidus. And nephrogenic diabetes insipidus is the receptor are having problem in the kidney. So diabetes insipidus is also two type. There is a big difference in these things regarding the urine specific gravity. In diabetes mellitus, there is, presence of glucose in the urine. Okay, glucose is osmotically active substance, so specific gravity of the urine is higher. Whereas in diabetes insipidus, okay, it's a diluted form of the urine. So specific gravity is low. Having said that, in diabetes mellitus, if the water along with that is excessive, then it may change, okay? So these are a very important point. Hyperparathyroidism and Conn syndrome are some other causes of polyuria and polydipsia. Hyperparathyroidism causes hypercalcemia, and that hypercalcemia is responsible for polyuria and polydipsia, whereas Conn syndrome, what is Conn syndrome first?
Excessive aldosteronism.
Increase aldosterone level.
Primary aldosteronism.
Exactly. This is known
Primary
as primary hyperaldosteronism. Primary, okay, hyperaldosteronism. See that. Let me write that for you, because these are the very, very important and basic terms. Hyperaldosteronism means there is something wrong in the adrenal gland, okay, like tumor or hyperplasia of the adrenal gland, and that is keep on secreting excessive aldosterone hormone without any stimulation. This is known as primary hyperaldosteronism or Conn syndrome. And you all know what is the function of aldosterone there, okay? So, but that probably will not give you explanation here. Now just think about it. Excessive aldosterone should actually retain more sodium and water, okay? So how there is excessive urine production there? And the answer is provided by another mechanism there. Hyperaldosteronism will cause hypokalemia because excessive potassium is secreted or excreted out in the exchange of sodium, and that hypokalemia is causing polyuria and then polydipsia. Now, whenever polyuria is there, polydipsia always follows, isn't it? Polydipsia means excessive thirst. The person will drink more water. That is the mechanism. Heat intolerance is seen in thyrotoxicosis and menopause. This is known as perimenopausal symptom, and palpitation occur in thyrotoxicosis and pheochromocytoma. So heat intolerance means, unable to bear the increased body temperature, either as a result of environmental influence or some other means. Means the person is feeling excessively hot in the same environment where other people are not feeling that much heat. That is heat intolerance. And the common causes are thyrotoxicosis and menopause as the perimenopausal symptom. Whereas palpitation is very commonly seen in thyrotoxicosis and pheochromocytoma. Pheochromocytoma is a tumor which develops in adrenal medulla, and that tumor secretes catecholamine. As a result of that, okay, palpitation is very common to occur because catecholamines stimulate the contractility of the heart. Now, some other common presenting symptoms of endocrine disease are thyroid nodule, especially seen in thyroid disorders, okay, of course, like in solitary thyroid nodule, dominant nodule in multinodular goiter, or maybe thyroid tumor. Generalized thyroid enlargement, also known as thyromegaly, can occur in simple goiter, maybe a nodular type of goiter or diffuse goiter, okay? Graves' disease, which I'm going to talk, and Hashimoto's thyroiditis. So Graves' disease is a feature of hyperthyroidism, whereas Hashimoto's thyroiditis usually causes hypothyroidism. So both of those situations, there is thyromegaly or enlargement of the thyroid gland. Prominence of eyes occurs in Graves' disease. Okay. That is prominence of the eye. Okay. Now let me ask that question for you. Which term we use for the prominence of the eye? What we call that?
Proptosis. Proptosis.
Thymus.
Exophthalmos. Exophthalmos.
Exactly.
Proptosis.
Proptosis or exophthalmos, both are correct answer. Proptosis or exophthalmos. One of the common cause of that is Graves' disease, which leads to hyperthyroidism. Now, hirsutism is excessive hair growth, okay, in unwanted area of the body, like in face. If there is excessive hair growth on face, especially in female sex. We call it hirsutism. The causes may be idiopathic, okay, we don't know. Polycystic ovarian syndrome, already talked about. Congenital adrenal hyperplasia, where there is oversecretion of androgen again, and Cushing syndrome. Cushing syndrome also, leads to oversecretion of androgen. So hirsutism is related with hyperandrogen secretion. Galacturia, okay, galacturia is milk discharge, okay, from the breast uh, in those situations where it is not normal. No, what I'm talking about here, not after the birth of a baby. There is a natural, galacturia during that time. If the lady is not pregnant, during that time also, if there is a release of the milk from the breast, then this is usually caused by hyperprolactinemia. Okay, now we need to find the cause for this. Maybe a tumor present in anterior pituitary, which is causing, or maybe some of the effect of the drugs. Now again, the same correlation comes here, the relation between dopamine and prolactin. Dopamine inhibits the release of prolactin. So if we use certain drugs which decreases the concentration of dopamine, or which blocks the dopamine receptor, it will indirectly lead to over secretion of prolactin. This is known as hyperprolactinemia. Let's move on. Another common symptom may be loss of libido. Okay, loss of sexual desire is called loss of libido. This is very common in male hypogonadism, also in female hypogonadism for that the reason. Visual dysfunction is very commonly seen in pituitary tumor. Now, there is one important term which is mentioned in the book. If there is a pituitary tumor, okay, the optic chiasma, which is present right above the pituitary gland, is compressed. And if this optic chiasma is compressed, the person will have bitemporal hemianopia. Bitemporal hemianopia. Very important question in the exam. Only the temporal side of the visual field is lost. Okay, temporal side of the visual field is lost on both sides. Another common symptom is headache. Headache. See here. Headache commonly occurs in acromegaly, pituitary tumor, or pheochromocytoma. Now, there may be different reasons for this. Acromegaly is related with pituitary tumor. Okay, pituitary tumor which secretes growth hormone in excessive amount. Because of that tumor inside the cranial cavity, okay, the person develops headache. Acromegaly is also associated with hypertension. That hypertension also can lead to headache. Pituitary tumor, so many other types of pituitary tumors are there. Okay, this is a generalized topic. So by causing raised intracranial pressure, it can lead to headache. And pheochromocytoma leads to hypertension, and that hypertension is causing headache. Okay, so there are multiple reasons. Let's move on. Sometimes the person may present with muscle weakness, usually proximal myopathy or proximal muscle weakness, and the causes can be thyrotoxicosis, Cushing syndrome, hypokalemia, okay, which is caused by Conn syndrome, hyperparathyroidism leading to hypercalcemia, and hypogonadism itself. So all of these can lead to muscle weakness in the patient. Paresthesia and tetany are the feature of hypoparathyroidism now. Now, tetany is a feature of hypocalcemia, and hypoparathyroidism definitely leads to hypocalcemia. Paresthesia means tingling and numbness sensation, which is very common in hypocalcemic condition. Recurrent ureteric or renal colic is seen in hyperparathyroidism. Now, what is the connection there? Why recurrent ureteric colic is seen in this disorder? Yes?
Because of
Formation of stones,
hypercalcemia,
formation of calcium stones.
hypercalcemia, calcium stone will form, which will lead to
Exactly. All of you have answered correctly. We all know hyperparathyroidism leads to hypercalcemia, excessive calcium secretion or excretion, I should say, in the urine, and that can form calcium stones, which results in recurrent ureteric colic. Coarsening of the feature, okay, coarsening of the feature is seen in acromegaly and hypothyroidism. Now, coarsening means the skin looks very thick, okay, the skin loses its elasticity. The deposition of certain substances there, which very commonly occurs in hypothyroidism, also known as myxedema, and acromegaly also. So all of these can be asked as a question in the exam, okay? So please pay attention. Let's move on. Now, please focus on this slide. This slide is taken from your textbook. These are the different, endocrine glands, okay, and the different pathology which is present inside them, or different manifestation also you can say. So pituitary and hypothalamus, the different disorders or pathologies are hyperprolactinemia, hypopituitarism, and pituitary tumor. Thyroid gland, hyperthyroidism, hypothyroidism, goiter, and carcinoma of the thyroid gland. All of these we are going to talk in our classes, okay? Because thyroid disorder is very important one. Goiter is enlargement of the thyroid gland. Pancreas, we are going to talk type 1 diabetes and type 2 diabetes in detail. The parathyroid gland, hyperparathyroidism and hypoparathyroidism. There are two different conditions, okay? From the breast, hyperprolactinemia. We are also going to talk about this in pituitary disorder. When we reach the adrenal gland, we talk about Addison's disease. Addison's disease is the hypoadrenalism, means adrenal glands are functioning at a lesser level. Cushing syndrome, okay, this is known as excessive cortisol secretion. Conn syndrome, you already know, and pheochromocytoma is a tumor from the adrenal medulla. Regarding the ovaries, polycystic ovarian syndrome or Steen-Leventhal syndrome, menopause, and subfertility. These are special topics in gynecology, so we are not going to touch them here. Kidney, okay, we have excessive renin secretion, and that can cause hypertension. From the testes, subfertility and testicular failure, and in the bone, we have osteoporosis and osteomalacia.